Black Urban TV YouTube channel. My name is Julius Okoyo. Leo tuko Kisii Town na tuko na Dr. Simiyu. Tunaenda discuss infertility, but before tuanze discussion wacha tuanze introduction from your side.
Hi guys, my name is Cliff. Welcome to Black Urban TV YouTube channel.
Thank you so much, Cliff. Thank you, Julius.
Thank you.
My name is Dr. Simiyu ambaye I'm a reproductive health specialist, an obstetrician and gynecologist, and I'm happy to be here today with you guys to discuss this topic.
Thank you. Obstetrician. Actually, go my obstetrician. If you can pronounce that word, it means at least you got a problem. Yes. So, doctor, normally, where I come from, once you get married, the next thing you want to expect from women ni mtoto. Yes. Okay. Now the challenge is kuna watu hawana watoto. So we're going to discuss fertility na infertility. I think it's the same thing.
Okay.
Almost. Yes. Maybe Cliff anaweza.
Yeah. So daktari, we just want to understand infertility.
Okay.
What causes it? What are the issues around it? What are the myths and misconceptions about it? Yeah, and some maybe some pathophysiology.
Oh, okay.
Yeah.
Okay. All right. Thanks so much. You know, I think you also come from where you come from. Because after marriage,
yes.
After wedding, then it's babies. If no babies, then there's an issue. And this is a very sensitive topic for generally in the reproductive health field. We see it very commonly, and it's increasing in terms of prevalence. We see a lot of clients seeking consultations for this. Funny is society just to think fertility or infertility is a women problem. So many of the clients we see are women, but in essence, infertility and fertility, it's a concern for both the man and the woman as a couple. So just not to digress, to maybe address the issue as it is. Infertility by definition will be inability for a couple to conceive after about 12 months of regular and protected sex. And that's what that means, therefore, in layman terms or in simple terms for the audience is you have to have at least a year of consistent and regular sex without protection, which is timed with an aim of fertilization around ovulation for about 12 months. If after that you've not achieved conception, then that qualifies for infertility. However, it also varies depending on a few things like age. Now we're defining them of later. For women who are above 35 years of age, we're now giving them even up just about 6 months. So if you go about 35 years, and you do about 6 months of regular sex without conception, we consider that infertility. If you're above 40 years, it's even less than 6 months. And all these things are dependent on your probability of conception. That's how we set the timelines. Now, previously we used to call it subfertility. They are almost used interchangeably, infertility and subfertility. And there are two types of this: primary and secondary infertility. So that primary infertility refers to a case of a client who has never conceived or had a pregnancy before. However, patients who had a pregnancy or have a baby in the past, and then they're trying to conceive, they go through the 1 year cycle of trial and they're not able to conceive. That's called secondary infertility.
Okay.
That by far and large defines it. Now, there are many causes of infertility, but broadly speaking, we say just about 30%, about 35% to 37%, according to the WHO, causes of infertility are female. So the female is responsible for about 35% of infertility. The male just for about less than 30%, about 27%. And the other percentage, about 27% again, is due to what you call a combination of factors, which could include sexual patterns, the timings of sex, or even multiple factors now, where it's both the man and the woman. And that's why I was saying previously, not previously, but even traditionally, people think it's a women problem, but it's not. And so maybe as that first take home message is, whenever we are trying to work out infertility, we encourage both the man and the woman to present for both history taking, examination, and workup for that. So if I just to maybe give a bit of overview of the causes in each of the categories, is that for females, this infertility can occur at any level of the reproductive system, all the way from the time when a sperm is supposed to enter the vagina, through the cervix, through the uterus, to the tubes, to the ovaries, the pelvis, all the way. Infertility can occur at any point. And some of the most common reasons could be what you call ovulatory problems. So ideally, normally the ovaries, every monthly, they produce, every cyclically, they produce ova that are now fertilized to form a conceptus. So in the majority of women, you find that occurs. But there is a subset of women in which that doesn't occur. It's called an ovulation, which means their ovaries are not either able to very sequentially and regularly produce. And there could be a million reasons for that. But some of them, and the most common, is number one, just age. Where we say in the reproductive age group, 15 to 49 years of age, in the 20s, about 15 to 26 years of age, that is the optimum moment of probability for conception. So that women at that gestation with the same partner have more than 50% chance of conception every other month. But as it keeps going into beyond 26 to 35, fair enough, but above 35, they will have markedly reduced chances of conception, because then the ova being produced are fewer in numbers and poorer in quality. You get it? So that women who have advanced in age may still be able to produce ova periodically, but the quality may not be good enough. So that is one. And that's why age, what the biological clock for women is an important factor. So, and of course, generally, with advancing age, then there are other considerations that complicate conception and pregnancy. The other reasons could be now what you call secondary causes that can cause an ovulation, things like diabetes, thyroid disease, renal disease in pregnancy, and sometimes, and even more commonly, medically we call it the HPO axis. Normally, for ovulation to occur, you need stimulation from the brain, for the hypothalamus and the pituitary to the ovary. Some women may have a problem with that, and all this requires significant evaluation when you are evaluating an ovulatory cause of infertility. So that's just one, ovulation as a cause. What is probably even more common than ovulation is what we call a tubal factors, the fallopian tubes that normally, ideally, should be able to carry the ova from the ovaries to the uterus where it's implanted. Anything that will block the fallopian tube will increase chances of infertility. And things that cause this are things like one, recurrent infections, sexually transmitted infections, chlamydia, gonorrhea. And for this to happen, normally it's recurrent because once you get an infection, the tubes are very small and they're very fine. But once you get recurrent infections, they keep healing with scar formation. So that the blockage of the tube is what prevents passage of the ova. That is one. Two, cases where you've had pelvic surgery. A fibroid surgery, any kinds of pelvic surgery sometimes, again the healing occurs with what you call adhesions. So you collapse the tubes, you reduce the chances of fertility with that. There are other things that are medical, call them hydrosalpinx and a million others, but essentially anything that will affect the patency of the fallopian tubes will increase the chances of fertility. You come down to the uterus, and many things that normally will reduce either the size of the uterus or the receptivity of the uterus. So for example, there are what you call congenital anomalies. People were just born with uterus that are either call them septate uterus, bicornate uterus. They either will reduce chances of fertility or reduce chances of being able to carry the pregnancy, and many other things. And then of course I've talked about the secondary causes. And then for men, normally infertility revolves around the quality of the sperms and the quality of sexual practice around it. So for men it's a bit straightforward. You want to look at the testis able to produce enough and quality sperms, enough in terms of the numbers. There's a parameter you use, And quality in terms of, are they mobile, are they progressive, are they of good shape, things like that. And what can affect this are things like, now again, recurrent infections for men, again, chlamydia, gonorrhea, but more commonly for men, it's what we call mumps or otitis. It occurs, it's otitis will refer to the testes essentially. So normally when, especially when people are younger, they get infections of the testes or the tubes that normally transport sperms. And that will also heal with scarring and prevent either the production of sperms or the transport of sperms. That is one. And of course, then other things like that you sure have heard about, like what you call undescended testes, where after birth, normally the testes should be outside the abdominal cavity, but in some children, when the testes are within the abdominal cavity, the temperature there is not conducive for sperm formation, and so by the time you discover that, you may not be able to produce enough quality sperms. And for men also, then there are other causes that we talked about, with the brain, with the hypothalamus, the pituitary, that normally will support production of the hormones. Support that is one. And I think that will, by far and large, somehow you will summarize the causes for infertility. I think maybe then I can tell you briefly about how you want to investigate this.
Okay.
Yeah. And so when patients come, as I said earlier, the focus is that we investigate both clients, the man and the woman. And the means of this starts with the history taking, and you look at their parity, especially for the woman. Has she been ovulating regularly? Does she have any chronic illnesses, issues like that? And then you do investigations that are tailored towards ruling out the causes we discussed earlier. So normally for women, what we do commonly, number one, is what we call a HSG, or a histosalpingogram. Just looks, it's more of an X-ray that looks at the patency, or how open the female reproductive tract is. So you see, is the uterus open? Are your tubes especially, are they open? Can they be able to pass sperms or not? Things like that. And that's normally probably the mainstay. We normally do other things like an ultrasound, just to rule out things like fibroids that can either be causing infertility or loss of pregnancy losses. And then of course we do have the hormonal profiles, again, which are what we call the FSH, sometimes the LH. These are a bit complex, but it's more of the hormones that normally will promote ovulation. And the aim of this is to know whether this woman is ovulating or not. And if she's ovulating, where is the problem? And for men, majorly we center on the semen analysis. Look at the amount of sperms and the quality of sperms. For men who have quality sperms and good number, then you want, and are still infertile, then you want to do probably images that will normally look at the patency of their organs, like an ultrasound or transrectal ultrasound, things like that. Yeah, in many cases, if you evaluate both clients and you address the primary concern, many of them are normally able to conceive. About 80% of clients generally conceive within the first 6 cycles of their trial of conception. Another 85% will conceive by a year. Now, in terms of management, then it's very strongly tailored to the cause of the infertility. Yeah. So, for example, if we find there's a hormonal imbalance in the woman that's not causing ovulation, then that's what you want to intervene at. If you find, for example, that things like uncontrolled sugar or hormonal imbalances like the thyroid gland, that's what you want to address first of all. So you must address the primary concern before then you center in on trying to solve the infertility. But by far and large, there are some common interventions that you normally make across the board that are thought to improve chances of fertility. So one of them is, when you come to us and you have issues of infertility for like a year or so, what you normally do, number one, is we encourage what you call lifestyle modification. A few things that will normally increase your chances of conception. One is smoking, stopping smoking. That has been known to be associated very clearly with reduced chances of conception. Reducing alcohol intake for 2 reasons. One, again, reduces chances of conception, and 2, in case of conception, then it has untoward effects to the baby. And then we normally encourage weight balance, so that especially for women, body mass index, that's average between about 18 to 25, like just a normal body weight is normally best for conception. But women who sometimes tend to be obese have to have higher chances of infertility. So normally encourage rate of weight loss to just come to within a normal body weight range, which normally comes with now normal regular cycles of menstruation. And then there's some drug that we normally give that will normally prepare the body for conception. Things like folic acid, and then some multivitamins, some nutrients like cobalt, zinc. They are normally thought to increase chances of conception as such. Beyond that, then now we look at the specific causes. In cases where the problem cannot be resolved after this evaluation and these interventions, then we normally proceed to the next tier of management. And especially for things like tubal blockage, previously we used to do what we call tuboplasty, which used to be we just open the tubes surgically, either through laparoscopy or even open cases. But we come to know over time that has still very little chances of conception. So nowadays we normally encourage that after a significant evaluation and these interventions already, if you're not conceiving, then we advocate for what we call IVF. IVF is one of the options that tries to skip some of the complications, some of the obstructions to conception. So the principle of the IVF is, especially if you have something like a tubal obstruction, what you are doing is you simply take an ovum and a sperm outside the body. You get here in a lab, in a test tube, and then you make them have a conceptus already. Then that you very finely implant it in the uterus, and you give it a high chance of survival. The point is you're trying to sidestep to bypass the blockage that normally happen with the tubes and issues like that. For many people, again, if you've corrected everything, you've optimized their care with IVF, they're able to conceive. But again, even with failure of that, sometimes they normally encourage other options like adoption, which are still very viable options in this era. And I'm happy that they're catching traction now. More patients are now willing to even take that as an option for childbearing. I think that pretty much covers the topic.
Thank you so much. Dr. Simiyu is a gynecologist. Hiyo jina ingine nimesahau.
I said obstetrician.
So uko na swali?
Dr. Simiyu has utilized almost everything. I think I have now 2 questions, just to expand a bit. Can contraceptives cause infertility? And how?
Okay.
And then this is not specific for men. For someone who has no history of any trauma, someone who has a history of having 3 kids who are his, then all of a sudden ED. What could be the cause?
Okay. All right. So these are the 2 questions I need to address.
Yeah.
And one is about the role of contraceptives in infertility.
Yes.
And that's a very common question. You get it day in, day out. And also it's maybe one of the areas that are much misunderstood. And many women, actually, the contraceptive uptake, the number of women who need contraceptives and actually get them is not more than 50%. Because of things, some of these misconceptions that are there. The thing about contraception is, one, it's very specific to the cause, to the type of contraception you're using. They're what you call hormonal and non-hormonal methods. So the non-hormonal methods, they just essentially form a barrier. Things like condoms and things like that. Normally those ones will have virtually no impact on fertility. And then there are things like even the IUCD. This is what you call the copper, the coil, which is a device you just insert in the vagina, in the cervix, the uterus, and then it prevents a pregnancy. Again, that one has almost no impact on fertility. You remove it today, you conceive as soon as you're ready. Someone who's used it, someone who hasn't used it are the same in terms of chances. Then now there are the hormonal methods. These are majorly contraceptive pills, the injectables, what you call the Depo-Metro. Many times they're normally progestin-based contraceptives, and then what you call the implants. So now, especially for the contraceptives, again, studies have shown for the pills that again there's almost no what you call the return to fertility interval is very short. You stop them within the next cycle you're going to conceive. But specifically for Depo-Metro, which are the injectable what do they call it? The injectable hormones, the injectable contraceptives, they have a latency, a bit of a long period after cessation that takes time to return to fertility. And this is because it's a drug you put in the body that takes a bit of time to break down, but generally it should not affect you beyond even 6 months. You get, yeah? So if let's say we are doing beyond even 3 months, actually 3 months after stopping of the injectable contraceptive, if you're having infertility, there's another cause to that. So if you were to put it in summary, contraception should not, whichever mode of contraception you're using does not necessarily cause you to be infertile. You investigate for another cause.
Okay. That is well answered.
Okay.
The
other one was about men who have ED and 3 babies are fine, and suddenly they have erectile dysfunction. One, erectile dysfunction and infertility in men are slightly different. So that erectile dysfunction is just the inability to either initiate and sustain an erection. And so it speaks more to sexual performance. While infertility is more of sterility, than inability to fertilize. So it's possible that someone with erectile dysfunction can still achieve fertilization, and that is one. But still, it affects in the light that the quality of sexual practice, then that light affects your chance of conception. But to your question about erectile dysfunction, how someone can get it, essentially there are many reasons for erectile dysfunction. One would be this: for the younger generation, men who are young, fit, physiological, without any known illness, they hardly have causes like that. With advancing age, generally, that's why you say maybe you have 3 babies, maybe you're now in your 50s, maybe. Then now they tend to have more cases of that because of even just the new things that come in, diabetes, hypertension, other illnesses that you may not think are related, but they are related. That is one. But by far and large, let's say there's no other medical condition, the leading cause of erectile dysfunction is normally a psychological cause. Either what you call performance anxiety, stress, not being relaxed. There's a lot to sex than just the performance as it is. And that's why sometimes a client will tell you they have erectile dysfunction of one woman, and then they don't have the same experience. So normally the first port of call, unless there are other known conditions, then psychological issues will normally come in first. But then of course there are other investigations that you can do beyond that.
Okay. Let me ask you something else. First of all, what is the prevalence? Are we supposed to be worried about the infertility right now based on the country?
So one, it's the cases are being seen more and more, but that doesn't mean probably we are increasing. It just means maybe we're having better health-seeking behavior. Maybe people are now more emancipated. They now have better knowledge and they can probably access healthcare better. That is one. But that said, if we were to draw from other related issues like the prevalence of sexually transmitted infections, which are increasing, then it makes sense that potentially we're going to have an increase in the cases of infertility with time. That is one. But also, what is coming up more and what is being very relevant is the change in lifestyle. For example, now most women are career women. You get here, and we are essentially taking the western path, where by the time many women finish academics, settle, achieve their goals, they're trying to conceive either in the mid or late 30s. I think that will independently be able to cause this. While for men it may not be very clearly related, for women it's very clearly related. So again, if you were to use that as a surrogate marker to guess, then it's very likely that we have more infertility than we had, or some fertility than we had previously. But generally, as it is, we're speaking right now, about 80% of our women in the population generally should be able to achieve conception within 6 months of trial, and about 85% within a year of trial. So that's not too bad. But if we were to look at the societal factors, then maybe it may be worse within that of time.
Okay. The next question is based on age. When is the right time for someone to go and test if he or she is fertile?
Oh, okay. You're calling it testing?
Yes. Like a 13-year-old cannot come and say that I want to be tested.
Yeah. So number one, I don't think there's something called testing for. Well, I don't know if I get the point exactly. Just testing for fertility.
Okay.
So normally we don't routinely do that. Unless there's an indication. So that's why normally say the only time when we initiate evaluation or testing for infertility is when a client has signs of infertility. But the default position is that you should go to conceive. So normally women of reproductive age will make an attempt. When they fail, we'll evaluate. But there's really we don't normally just do tests for fertility. But I almost got your question in this regard, that probably which is the best time to conceive. Yeah, those related.
Okay, I think my question was like, we have people, okay, a child, let's say, who is 13 years or 15 years. Can that child come and say that I want to be screened to know whether I'm fertile? Or there's specific?
Oh, fine. So what I was saying is even if you're 27 years, it doesn't make logical sense to come to be screened for fertility unless there's a problem. That is one. But two, for a child who is 13 years, this thing depends on the ovulatory cycles. By 13, the very early years of puberty, there are chances of conception, yes. But then many times the first cycles are normally what we call anovulatory and irregular. You get it? So normally we don't give much emphasis for that age group in terms of evaluation. But the optimal period, the highest chances of fertility are normally between about 18 to 26 years of age. You get it? And so normally if you saw many clients who came here that generally even the guidelines in the country are not for routine pregnancies and things like that. So I'm not certain you'll find many gynecologists who are keen to be screening a 16-year-old for fertility. But generally in the setting of probably about 20 years or so, then now you can probably do a lot. But even then, only after you see an indication.
Okay. Maybe my two last questions. One is, are there people who produce semen without sperms completely? And also, based on your experience, what are some of the misconceptions that at least your patients present? And maybe the last one, because of where we come from, you'd see our society don't take infertility lightly. Do you do counseling once someone's, let's say, has tried so many of these steps and they cannot achieve to get?
Okay.
Yes. So that's my last question.
So the first one was about lack of sperms. The second one was about I remember the third one. The third one was about counseling. The second one was about what is it?
Oh, misconceptions.
Right. So the first question you asked is about if there are clients who have totally no sperms, and that is true. I just didn't go into details about it earlier, but we call that azoospermia. Azoospermia means you have ejaculate, you have semen, but they're totally without sperms in them. What is even close to that is called oligospermia, which means you have semen, you have ejaculate, but with sperms, but a small number of sperms that are not able to fertilize. Yes, that's it. Yes, they are there, and this is among the leading causes of male infertility. Many of the causes of this are normally congenital or genetic. So you are born genetically deformation in terms of your makeup. So the things we call either Klinefelter syndrome, things like that, that would normally hinder the formation of the male gamete. That is one. And of course then even the hormone testosterone that normally will be able to promote the formation of sperms and things like that. So if you are genetically impaired, then that will affect that. But for you to be able to get total absence of sperms, it's normally congenital. many times. Of course, the other things I talked about, people who work in industries, sometimes with exposure to lead, mercury at high levels and radiation, sometimes they tend to destroy the sperm forming capacity. But in those cases, mainly you find what you call oligospermia, little amount of sperms that are not able to fertilize. About 15 million per milliliter is the normal required amount. So you find they have less than that, and so on. And sometimes you may find they have a good number of sperms, but either they're not of good form, so they keep going round and round in circles. They're not progressive. Yeah, many of them are normally
but 3 months.
Exactly. So you won by being alive right now. You won assuming cortex at some point, and that's fixed it. But that would be one. And true, if there are any misconceptions about infertility, there are many, and one and the most important that I mentioned to you earlier is that infertility is a female factor. So that when people are married, no baby coming, then they put pressure on the woman specifically. And they tell her, I've seen cases where even the woman has 3 children elsewhere, a man has no child elsewhere, but when they meet and they have ability to conceive, then it's still the woman who is a problem. That's probably the most important misconception I've seen. The other misconceptions I've seen about sexual practice. People think, for example, having sex daily, consistently, all the time, increases your chances of conception. So you find couples telling you, okay, that's when I'll come to that. Okay, let me just talk about that first. Couples telling you we have sex so regularly, every day, month, from day one to, we're not conceiving. And while that is not entirely wrong, the truth of the matter is that the highest chances of fertility are around ovulation. So if you are looking for conception, then you need to know when you're ovulating and have sex a day, 2 days, or on the ovulation day. A day, 2 days, 1 day before the day on the day ovulation itself. It makes the chances maximal. But generally, to make it easy nowadays, we say having sex generally about 2 to 3 times a week is enough. Now, if you have what we call a period of abstinence for the man for about 3 days before ovulation, then it increases the chances of conception, because then it increases the quantity and the quality of sperm. But now the very regular daily sexual program sometimes tends to even work against conception. And then the other thing is, of course, not really a misconception, but a bad practice, where class will come to you and tell you, I've been trying to conceive for the past 3 years. And when you talk a bit of the history, they tell you, my husband lives in Nairobi, so he visits once in 2 months. You get it? And then they've been trying for 3 years. You get it? And they say they're infertile. You get it? And that speaks what I was telling you earlier. For us to discuss infertility in you, then there must be that consistent, regular sexual practice. So I don't think that is another bad thing. Someone will tell you, my husband is in KDF. He comes once in 6 months. But they hope that one time when they have sex, which could be random and periodic, they assume that should go to make them conceive. The other myths about, of course, tribes. They say this tribe is very fertile, this tribe is very fertile, I see lots of that. And they tell you, should I try another tribe? I've been in this for so long. So studies have shown that, generally speaking, there's no superiority in terms of ethnic composition. And of course, one of the last ones that I find very interesting is about sexual positions.
Yeah.
Patients will tell you, and they even tell me this myself. They tell me, my first child, there's a sexual position I adopted to achieve, and I think whenever I use it, then it works for me. But then with other styles, it doesn't work. And they tell other women in salons, in everywhere, and it goes around. They tell you sometimes that after sex, there's a way you should remain. Just lie flat in the bed, lift your legs in the air for like 10 minutes, things like that. So studies have shown sperms are about swimming, not about the position. Studies have shown that all those things are what we call, we used to call them old women tells, but they say that they are myths. There's no relationship between the sexual position or the styles you use during sex in terms of infertility and fertility.
The last
counseling. All right. Thanks. I almost forgot. So, fertility, as I told you, is one of the most distressing factors because it looks like a societal milestone. Normally, just after finishing school, after getting a job, what you want is a baby and family, and that sets you apart. So, it's normally very distressing, both for both clients, and it's normally among the leading causes of either infidelity or divorces in this area. So we normally invest a lot in terms of counseling and psychological support, and this has been shown to improve chances of conception very much, because again, most of the clients we evaluate don't have anatomical defects or problems. They probably just have a problem with anxiety, stress, and things like that. So normally when you work them up, and even that workup we do, that investigation we do, sometimes assures them, and then we take time to counsel them, then many of them will normally be able to conceive. Yeah. So there's, I don't think it's being done very aggressively, probably in the public sector. It's more robust in the private sector, but it will be a good practice. And it has a direct bearing on the improving the chances of conception and even just quality of life, assuming sometimes conception doesn't even happen at all. You get you? If patients are well counseled and they understand, then it generally improves their quality of life and improves their options about life.
Thank you so much. Lakini kuna moja yenye nilikuwa nimesahau. One of my friends from Nairobi, I think alinitumia message. She did IVF. Then this is the second time ana miscarry after anapoteza mtoto.
Okay.
Yes. So it may happen 2 times. Is it related to infertility, or that is something totally different?
Not related, but they're related in the sense that, number one, you can find that the natural process of conception, and many women take this for granted, many of us take it for granted, but the natural process of conception is the best. Just being able to mate and conceive without intervention is normally, it reflects that your bodies are optimal. You get good hormone balance, good metabolic balance, and they have the highest chances of carrying a successful pregnancy. Anything else that you do that is artificial is a trial. So IVF has success rates that are less beautiful than the normal chances of pregnancy. One, because sometimes the problem that caused infertility is still present, even after implantation. Because what we do sometimes, when you have a hormonal problem, we try to supplement you with artificial hormones like progesterone, and these are supposed to sustain the pregnancy. You get it? But they do not work as optimal as probably your normal hormones. So one, it's true that the process of IVF has a higher failure rate than normal conception, either because of the underlying cause itself, but generally because it's a natural process. Many women, what we do sometimes, we implant more than one over. After implanting more than one over to increase the chances of conception, but even then it's still a 50-50 chance. But it also goes with the amount of technology and skill that is available. In Kenya, we're just catching up to that technology right now, but in the West, they've improved the chances very much over time. So I think hopefully, maybe with time, we can do better and have better rates of success. But for now, that is the truth about it.
Thank you so much. Unless you concern.
I don't have any question.
Nini unaambia patients wako?
It's been nice meeting you. The take-home message about infertility, I can say, is let's do what we can about it. Sexual practice, if you can regularize that, and lifestyle behavior, things like responsible sexual behavior, having faithful partners, reducing chances of STIs, it does well for that. True. Issues, of course, like tobacco smoking, alcohol intake, the things that should be done with regulation. And of course, for my patients are normally generally women, I would advise the balancing of life, work-life balance. All these debates are easier had for gynecologists in women of a gentler age group, in the 20s, early 30s. It's a beautiful discussion to have. It's much harder when we're doing the late 30s and above. So normally, if we can have these discussions and these attempts earlier, then it probably works better. But of course, I understand that there are other considerations that but infertility has a cure, and it should not be looked at the way society looks at it right now.
Okay, thank you. Kama uko hapo hivyo, make sure na subscribe, comment hapo chini topic unataka to discuss next. This is Dr. Simiyu, become gynecologist, Kisii.
Thank you so much.
Thank you so much. Bye guys.
Bye.